So hi again, everybody. Troy Jorgensen. I am the program manager for Project Echo Nevada. Glad to have you joining us today.
Hi, good afternoon, everybody. Mordechai Levi here. I'm a geriatrician and medical director of Project Echo Nevada. Yesterday, I was able to watch the Super Bowl, and I think and I ate almost an entire pizza, so I was pretty happy with that. So that's my interesting fact for the day.
Hi everyone, I'm Teresa Watts. I am an infection control nurse at a nursing facility and assistant professor at UNR. My fun fact was that for the first time in a while, I took the weekend off. So it was really enjoyable for me to just have the weekend for myself, and I did not watch football, but I did spend quite a bit of time outside.
Mark Pandori. I'm the director of the Nevada State Public Health Laboratory and an associate professor of pathology and laboratory medicine here at the UNR School of Medicine. A fun fact about me is I'm a character in a book that was on the New York Times bestseller list called Bad Blood. I'm not going to tell you what character I am in that because it's pretty obvious by my name if you read it. And that's my fun fact.
I don't see Steve Matlis on with us today, so Regina.
Hi all, how are you? I am Regina Neal, the QI coach, and I don't know if it's a fun fact, I'm in mourning since Kansas City lost.
Thanks, Regina. Dr. Phillips is next.
Hi, Steve Phillips, geriatrician. I guess a couple things. On Saturday, celebrated this birthday of my twin grandkids, Ethan and Quinn. They turned 7. So I now have 2 7-year-old grandkids and 2 11-year-old grandkids. So my wife and I will be taking all 4 of them to 7-Eleven for their treat in the not too distant future. And I have to say, I'm actually celebratory because a 43-year-old quarterback won the Super Bowl. Thanks.
That's a fair point I hadn't thought about, but I'm still in mourning.
All right, Sneha, go ahead.
Hi, my name is Sneha Sharma, and I'm the program coordinator for Project Echo Nevada.
All right, and Nathan, yep.
Hi everyone, my name is Nathan Militante and I am the program coordinator for Project Echo. Fun fact about kind of what I've done recently, I am also doing Olympic weightlifting, so clean and jerk and snatch, and I'm on my 7th week of my 12-week program. So busting it through and getting stronger.
All right, thanks, Nathan. So that's our team here today. Now, if you haven't done so already, please just be sure you write in your name, credential, and location through the Zoom chat box for us today, and then we'll pull up our Zoom poll here as well. So first question here, what kind of visitation options do you have related to visitation? Select all that apply. So do you allow outdoor visitation, indoor visitation in a designated meeting room, indoor visitation in a residence room, window visits, visitation with plexiglass barrier, virtual visits using a tablet, computer, or a laptop, or you don't have a visitation policy. Question 2, how often do you follow your visitation policy? Always, most of the time, half of the time, sometimes never or no policy. And last question 3 here, do you have enough resources to follow the visitation policy? Always, most of the time, half of the time, sometimes never or no policy. So appreciate you all responding to those questions there. We'll give it a couple minutes, then end that and look at those results. All right, just another few seconds here for that poll. All right, so looking at our responses here. Question 1, what kind of visitation options do you have related to visitation? Select all that apply. Things are going to be a little skewed here in terms of the percentages just because of the select all that apply. But it looks like the top response here just barely was virtual visits, followed closely by window visits, and then in third place, outdoor visitation. So top 3 again, virtual visits, window visits, and outdoor visitation. Question 2, how often do you follow your visitation policy? Majority, 86% said always. And question 3, do you have enough resources to follow the visitation policy? Most of the time, 49%, and then shortly followed by always, 43% there. All righty, thank you all for responding to that poll. All right, so move on to our case review and discussion today. We did not get any cases submitted from the group here, nothing that came in through that online form that we have, but definitely want to give you an opportunity here. Any specific cases or questions that you'd like to discuss here today, feel free to unmute yourselves or write in through the chat box. We'd be happy to discuss those. And these don't necessarily need to be specific patient cases. They can be general questions or any points of concern that maybe you've had the past week that you want to discuss with the group here. So looking for anything, feel free to unmute yourselves or write in, please.
This is Julie at college. I would like to just see if others are, I'm sorry, Terry's computer. I'm just.
Yeah, Julie, we could hear you there. It seems like maybe you've got somebody else joining. Yeah, just need to turn down the microphone or the.
Yeah, she's done in a different computer. Okay, I'm just wondering if others are having a similar issue with the testing situation. So we use a lab as well as obviously we also have the in-house. So, and we still get different readings even from 2 different labs as an example. So I'm just wondering with all the confusion in testing sometimes what people are doing in regards to receiving a positive, then a negative, then trying another lab and getting a negative or a positive. I mean, I've never seen so much confusion. Normally no signs or symptoms or anything. So we're certainly watching and doing what we need to do, but I'm just wondering if others are feeling the same thing in the confusion in the whole testing and where people should end up during this kind of confused time.
Thanks for sharing, Julie. I guess we'll kind of start off. Just one quick question. What specific tests are you using on your residents and staff? Is it the
BD Veritor? We have the BD Veritor in-house, and then we're using 2 different types of labs. Basically, if we have 1 lab, but if we need to, we have a second lab backup. And even those can vary. That's what's so difficult at times. So that's why I'm just wondering if it's, I don't think we're probably the only ones with that somewhat confusion going on.
Yeah, I imagine there's lots of.
This is Mark Pandori. Just a few comments, if you don't mind. Well, there's definitely a specificity and sensitivity differential between the Becton Dickinson Veritor and the lab-based tests. So discordance between those 2 tests is not surprising, considering the specificity of the BD Veritor appears to be quite poor. Sensitivity might even be somewhere in the neighborhood of 80% that of a lab-based test. So any discordance between lab-based tests and point-of-care tests wouldn't really be a technical surprise. So you see a lot of false positives with the Veritor. The Abbott, and I see someone is chiming in here actually with what is truth in terms of being backed up by data, and that is that the Abbott rapid test has far fewer false positive results and is apparently more sensitive than the Veritor. Now, the difference between actual labs is also possible. We actually saw this last week we had a specimen question here at the public health laboratory because the specimen was tested at one lab and was positive. Same person was from the same day was tested, and I don't know why they were tested at the same time at two different labs, but they were, and they had discordant results. Turns out one of them was tested by a hologic Panther, and the other one was tested by the real-time PCR by the I'm sorry, like either the Thermo Fisher or the CDC real-time PCR. It turns out that, and then there's a paper in the Journal of Clinical Virology that talks about this, which was authored here at the Public Health Lab, where we head-to-head compared the hologic and the real-time PCR and found that the hologic was about 50 to 100 times more sensitive for virus than the real-time PCR was. So even between labs, the technologies have different sensitivities. And one of the things that appears to be going on as well is that some people are very, very weakly positive in the nares or in the nasopharynx, but they're more consistently positive in the lower respiratory. So a sputum or bronchoalveolar lavage might reveal a positivity, whereas in nares or in nasopharyngeal would not. And in those cases where the PCR is very weak and perhaps unable to detect in the nose in such people, it turns out the hologic Panther can detect those given its much, much higher analytical sensitivity. So it is possible to see discordance, and it doesn't necessarily have to track back to poor lab practice as much as it tracks back to actual technological differences and performance issues in these tests. I hope that's helpful. And I'll note, as someone did in the chat, that what I said about the Veritor appears to be also true about the Sophia. Thank you.
Thank you. I just wanted to make sure that it wasn't just our building feeling this confusion, but it's clearly out there. So that does help. Thank you a little bit.
Sure.
Mark.
We've seen about 4 or 5 such cases where there's a discordance between labs that might have to do with hologic versus PCR. Sorry, Steve.
No. I just question, because it came up over the weekend at the birthday party. Apparently the MBA has what's considered one of the best testing. They do sputum. Is that correct? Can you comment on that?
Saliva, I think.
Saliva. Thank you.
Yeah. I'm sorry.
Can you comment on just how, is it really that?
Saliva, apparently, the studies vary. I saw some data, I don't know if it's published yet, where the Gates Foundation did an extensive study looking at saliva. And I hope that this study gets published because they had a lot of data points. And that showed actually that the saliva was just as good as a nasal swab. A nasal swab in the hierarchy is considered 90 to 95% as sensitive as a nasopharyngeal swab. And in at least one paper, the nasopharyngeal swab is about 90% as sensitive as a sputum, a lower respiratory specimen. So there's a hierarchy. Sputum seems to be consistently the best, but it's a very hard specimen to work with and to take. So of course we don't do that for routine testing. And then your nasopharyngeal, and then your nasal. And then, as I said, in the study I saw, the saliva was as good as a nasal swab, but there is another study out there that shows sensitivity of saliva to be, I think, somewhere in the neighborhood of 90 or 92%, that of the nares. So it's either as good or about as good in terms of being about 90, 92%. Right. That's all I know right now.
No, that's really helpful. They claim that that's why the NBA keeps having players on the court more often than anyone else. So
yeah, I think the bubble concept helped them quite a lot as well.
You're right. Yeah.
Hey, Mark, just quick, wanted to make sure I was understanding what you were saying. So quick, just kind of let me know if I got any of this wrong, but sounds like lots of our nursing homes have these point of care antigen tests, the VD Veritor, the Sophia, the Abbott have kind of been mentioned. And when we kind of refer to the lab test, we are referring to kind of that PCR test. Generally, those kind of can be used synonymously.
Most often it is PCR. The hologic uses a different methodology. Yeah.
Okay. And you kind of talked about the sensitivity earlier. Okay, and so kind of the sensitivity, specificity, the kind of internal characteristics of all those point of care tests are all different, kind of leading to the differences between the results that we're getting, especially compared to that more sensitive lab test. Is that a fair?
That's an accurate statement, yeah.
Okay, cool. just trying to make sure I was following. Cool. What other questions are out there about testing or these, or kind of interpreting these lab tests and kind of these real world experiences?
One thing I can add, we had a situation last week from the coroner where the person had every symptom, the deceased had every indication of having died from COVID-19. There was a negative nasopharyngeal swab by PCR, positive by the logic. And when the swab of the actual, because it's a deceased individual on autopsy, swabbing the lung was positive by PCR. So, there's still some physiological, things going on with this disease that maybe we don't fully get yet. Or maybe, it's just that the lung or the lower respiratory is much more reliable for replication of the virus.
That's really interesting. This is Steve, but from a health plan standpoint, it's I don't mean to be morbid, but with COVID-19, CMS is looking in all of their stimulus packages, how to offset some of the incredible costs from COVID-19, hospitalization, mortality, all that. And it's extremely important, even for a coroner, if they think there's a possible COVID-related death, they got to capture that.
Interesting. Well, that would explain the doggedness with which this investigation was being pursued.
Yeah.
Glad we
I was
really-
wondering, Mark, if maybe that's why I just wanted to add that. I mean, we know within Hometown Health across the state, so far we've had 525 COVID-19 related admissions, and we have 82 deaths.
Oh,
And we're keeping that information and readily available because it's going to become very important down the road. Not
yeah,
only, I'm not saying you don't. The concern is not just around the death; it's just financially. Medicare is looking to increase by up to $40,000 for a hospitalization that's COVID related. And if a death results from it, it could be another $15,000 to $20,000. I mean,
wow.
so I like the doggedness. That's why
Yeah.
they are dogging it.
Yeah, it was the second time that we've been, assisted the coroner in such an investigation.
Yeah, I always find that they should tell us that up front, right? I only know about it because of my role with the health plan. But it makes it a little more palatable, or why it's so important.
I see. Yeah, I never appreciated that. Thank you.
You're welcome.
Yeah, just a couple of comments I want to mention in the chat box here about the Abbott test. Misty says, find Abbott more accurate versus Sophia. And then Anthony says, we use Abbott in our private lab and have not had any real problems so far.
Well, there's data now published to support that. Just a really big study done in San Francisco shows the performance characteristics of the Abbott Binax to be superior, really almost that of a lab test.
How tough is it to get your, sorry, Mordechai here. How tough is it to get your hands on one of those at this point if you don't have one?
It's very difficult. Well, actually, my understanding is that the state, while they're not going to support, they can't support the ID. Remember the ID now, the molecular point of care. While that support is going away, the state is looking to continue to obtain Binax now, the rapids from Abbott, and keep supplying those to the state. But there is going to be a lull while Abbott catches up with production on that. I don't know how long that'll take, but the state is going to continue to support that, to my knowledge. But at this moment, my understanding is it's pretty hard to get your hands on those.
Excellent. Thanks, Julie. Really appreciate your question.
Thank you, Julie.
The discussion here.
You're
Any
welcome.
questions today?
Hey, Troy, Steve here. I just want to put out to the group, now that we're really down the road with vaccination of residents, and we're talking about visitation today, any thoughts of where we go from here, or where U.S. facilities want to be going? I've seen some work across on the East Coast with assisted living facilities as they've gotten to like 90+% of their residents vaccinated, and staff at like 80%, of looking to increase, at least in the ALF space. That's like a Brookdale nationally. Any thoughts? And Teresa, I'd like for you to chime in as well. And I think it's, times are going to change.
So I think I said this last week, and I still continue, that I keep looking for the guidance from CMS and CDC for when we can change. It should be some sort of reward that when we achieve these vaccination rates where they are very high, what can we offer for our residents so that we can safely allow some activities, visitation, or whatever they may have you. We achieved a vaccination rate among our residents around 84%. And among our staff at my facility, it was around 74%. And we have another vaccine clinic coming up, and I'm hoping to get some more staff and the new admits who are coming to our facility. One thing I'll just kind of mention that I did was this past week, our facility had resident council, and it's just, they only had a few people due to social distancing at the resident council. But I wanted to hear from the residents, what do you want? What do you feel like we need to do better in our facility around visitation and activities? And pretty much they said, we want more activities. They miss going outside, they miss having musicians come in, they miss all these things. And while even though they said that, in the same breath, I'll add that they also said that they want to make sure that it's safe. They don't want musicians coming if their musicians are unvaccinated. They don't want musicians coming if they're untested. So they had this sense of like they're missing things, but they also had a sense of awareness of protection and, making sure that COVID does not being brought into the facility. I guess I would like to say that I actually found this practice of asking the residents quite rewarding. And I've also done it with the staff at another time. And so it is something that I think that infection control preventionists can go forward and do to see, to get the residents' perspective of what they're missing and what they want. And I think this is important too, because as there's no state and federal guidance, it helps us to kind of work within the realms of what maybe they want and modify and kind of get some things that work within what they're asking for, while also maintaining and following the state and federal regulations. So I did find it quite a rewarding experience.
Well, that's really, I appreciate that. And Bridget, since you go out of state, I believe, at least with the organization, is there any difference from, what, say Texas is doing versus Nevada, or?
What we see primarily across the country, the only state that we really struggle with doing things differently is New Mexico. For this particular company, they kind of write their own rules and send them out, and they were last to approve PCR testing. But if you look at the numbers, they're actually down to monthly and bi-monthly testing, where Nevada is still twice a week. So it's really interesting. I don't know how they're controlling everything, but they do things very, very differently. For one example, they just put out some information in the past, I want to say 3 weeks, that now all employees going into the facility have to change their clothes when they get to the facility, but they can bring the clothes with them. So they're coming from their home in their clothes to change their clothes into clothes that they wash in their house. So I don't follow that line of thinking, but we had to create a way to do that so that we didn't get state tags. So that's just an example, a couple of examples of how different New Mexico is. Otherwise, across the country, everybody, to Teresa's point, is pretty much following the CDC and CMS guidance at this point. We don't have anything new. Our internal intel, we're not sure that we're going to really have a lot of information for the next few months, or that we're going to see any new vaccination up, especially for our populations, until at least fall, based on the way that they're rolling out the vaccines at this point. We're not sure what that's going to look like. So somebody had put in the chat a few minutes ago, what happens when you get to your third vaccination clinic? What happens next? We don't know. We honestly don't know. We're just going to have to protect everybody the way that we do. It looks like if everything keeps trending down, that we'll start to reopen a little bit. All of my buildings have reopening action plans in place. In New Mexico, I'll be reviewing those and trying to open up for visitation again. Nevada, we're not there yet. Did that help, Steve?
Well, that was great, Bridget. I really appreciate it, because it brings a, out of state, out of mind perspective. I mean, literally, not the cop Billy Joel, New York state of mind, but
another thing,
yeah.
we are, and not to interrupt you, I'm sorry. We are
go ahead.
That the survey process in each state is open to interpretation. So even the federal offices, not just the state offices, it's sort of like reading your Bible. It's open to the interpretation of how you read the regulation. And so in every state, we're being cited for different things in different ways, and even the feds aren't following their own regs. So it's open to local office interpretation, which is a problem for all of us to be able to do what we do well. And then I think, to your conversation earlier, keeping the numbers of deaths is very, very difficult for us, given that Michelle and I have beaten this to death since last March, knowing whether they truly died of COVID or was it the comorbidities. And to somebody else's point, we're still not sure entirely clinically what we're looking at when we drill it all down. So I'm not sure that the numbers are ever going to be right when you go back and look at all of it. Because if I'm a hospice patient with, end-stage liver disease or cancer, did the COVID just exacerbate my process? Was I actively dying before I got there? But then I just happened to post-mortem swab positive with no symptoms that we would have seen. So I think it's going to be really, really difficult to ever clear the weeds.
Teresa, did you have some thoughts?
Yes, I did. I mean, so many thoughts now, but I want to start with the third clinic. So I reached out to our pharmacists. We're working with CVS and my facility. And I said, well, what do I do with the third clinic? I said, can I get people first dosed on the third clinic and then have an appointment set up through CVS? And they said, yes. So if you have new staff, new residents coming, and if you have, for the resident side, if you have like a transportation service, essentially you can set up appointments and bring those residents to their appointments to get the vaccine, should you just make those appointments. I haven't done it yet, but I was told by CVS that we're going to be able to make appointments for second doses or first doses for staff and residents. Second, I have been having this conversation about case definitions around COVID deaths with the state, and I've been having quite a few conversations around definitions with them. And I'll just upload a document that they sent to me about the case definition for COVID-19, because we had several deaths that were, people were recovered back to their normal self, and then, 2 months later, whatever it was, time frame later, they then died. But basically, if you read the case definition, and if it's a death within 30 days from onset of their symptoms, or if COVID's listed as a cause of death, you have to report it as a COVID death. So if you just review the case definition, which I'll attach in the chat, it could give you some more guidance on what the state reviews as a COVID death. And this is just the state of Nevada. New Mexico might do it different.
I know when it comes to reporting COVID deaths, we had a patient who had no symptoms whatsoever, nothing. All of a sudden he coded from a heart attack. He was tested post-mortem and he came up with COVID positive and had no other symptoms ever. And they ruled him as a COVID death, which I don't completely agree with. We had 2 or 3 hospice patients who died, who were tested positive for COVID post-mortem, but they were already on hospice because they were dying from something else. So that's where my thing is, because that's what Bridget and I discussed all the time. Well, it's counted as a COVID death, but do we really think it was a COVID death because they incidentally came out positive for COVID afterwards?
Yeah, this is Steve again. This is tremendous conversation for me. CDC and CMS, since I work with CMS very closely through the NCQA, National Committee for Quality Assurance, and a couple calls a week between CDC and CMS and myself. My recommendation has been you kick it out 90 days from a positivity, especially in this vulnerable population, that you have to somehow capture. May not be the, like the state of Nevada calls for acute respiratory distress syndrome as a consequence of pneumonia, as a consequence of COVID-19. It may be cardiac arrest as a consequence of COVID-19, if it's within 90 days. And it's because of this whole long haul, especially in this population. So yeah, I appreciate Michelle and Bridget and Teresa's perspectives. It's very confusiform, and we can't necessarily go back. Though, if I could stop writing death by COVID right now, I'd be a happy person, because I have to have done 100 death certificates since March, just around COVID, in our practice. So yeah, but it has to get captured however we can. So I agree. For me, it's no doubt 30 days. I've actually kicked out personally within our practice 90 days, and no one's pushing back on it.
So I'm struggling to upload that document. So I unfortunately can't send it, but I'll send it to the team to then send it out to you all.
Sounds good. Appreciate that, Teresa. Tanella shares in the chat box that Walgreens said the same thing last Tuesday at their third clinic. So kind of what Teresa said about CVS, same thing for Walgreens.
Right.
Excellent. All right. Appreciate the questions. Anything else we can help with today? Question here from Wanda. Who does the post-mortem COVID testing?
I believe it's the coroner that does it. At least the coroner, I think, did it in our cases for postmortem.
Dr. Pandori?
It sounds correct to me. I mean, we run tests for the coroner, but it does appear sometimes the coroner does send out to another lab. So I don't know how they make that decision, but the coroner will do testing. We'll take specimens for testing.
All right, thank you. Sherry asks here, how realistic is it to take residents to an outside clinic if they're bed bound? Sherry, I might just ask if you can unmute yourself and ask your question that way. Sherry, do we have audio for you? If you just send a request to unmute yourself, if you just accept that and you have a microphone, we should be able to hear you. All right, maybe some issues there with unmuting you. So Dr. Levy, I'll kind of ask you to take this.
Yeah, so I think this is probably a question going through everybody's head. If you're thinking about transferring your patient to a CVS or Walgreens that has limited mobility, potentially bedbound, is it realistic? How realistic, or what are the logistics associated with getting this person vaccinated? One thing that I think I'll throw out there to begin with, as we kind of share ideas, that I think a lot of these are, I'm not sure what CVS and Walgreens will do, but lots of these are drive-through vaccinations as well. So you don't get out of your car. Usually you're at car window, but would throw it out to anybody else as far as what ideas you have as far as what Sherry was asking.
One thing that this makes me think of, and it's something that has been on my mind for a long time, is why can't we have the vaccine available in our facilities? because it is sometimes, for some residents, it is a challenge, and to get them, to their appointments or whatever. It's not impossible, but there's an added level of challenge. And like, if you have a vet unit, maybe you have to have extra staff transporting with the person who, the resident. And so I think this really gets to the fact that I think us as facilities need to have the vaccine or have access to it in-house. And unfortunately, we're going to be dealing with the challenges until we get that vaccine available for us. So my suggestion would be, it's going to be however you get your residents to appointments elsewise, what other sorts of means that you have to do that. And you might have to pull extra staff to be able to make that possible. It's a challenge, but it's one we're going to deal with until we get our vaccine in-house.
Yeah, and this is Steve. It's logistically, the Pfizer's out of the question because of the freezing. Once it's thawed and it's distilled, the mixing that has to be done, you have 10 to 11 doses per vial. Shelf life is less than 5 hours. I mean, out of refrigeration. Refrigeration is 4 days. So that one's tough. Moderna's a little better. I think, Teresa, to your point, I totally agree. Once we have other ones available, whether it's Johnson & Johnson or whomever, but it's also just how long, if you have a vial that's good for 10 vaccines, and once you start using it, it's only good for 5 to 7 days. It becomes really tough. Though we should be able to think out of the box. I mean, so CVS or Walgreens, whoever's serving that nursing facility, draws up 5 or 6 syringes and they go directly to the facility. I mean, logistically it can be done. It's just, I think getting that acceptance. I know for Nevada, pharmacies across the state will start having the vaccine on site. So it's no longer going to be just CVS and Walgreens next Monday or Tuesday. So it's Save Mart, all the other pharmacies will have it available. So yeah.
I hear what you're saying, Steve, but there's an issue with that too, because as nurses, I mean, I've been mixing and given medications for how many years now? When I started in this career, I mixed my own drugs in an ICU and wrapped my knife with tinfoil, okay? And I didn't need a pharmacist to check off on it. So I'm a little confused, especially if we have trained certified infection control practitioners in our buildings. And I know my deal is, so I don't know. I think that there's some ways that we can serve our population in our buildings. I personally, and I'm going to say this out loud, wasn't comfortable with the pharmacist giving me a shot. I wanted to give it myself, actually. But I'm a nurse. That's what I do. Anyway, just saying.
Well, I kind of took that as you support that concept of taking it, and that's what I'm saying. It should be in-house, though it has to be where it can be stored. And see, once that, and I just pointed out Pfizer, because once that vial is thawed from minus 72 degrees or whatever it is, and then it's mixed with normal saline, which has to occur, and that's why they get typically 11 doses instead of 10. And then it has a very finite shelf life. My thought was, we don't want to waste vaccine if we don't have anyone else to give it to. That was I
get it. And in fact, some of the pharmacists that came through one of our buildings actually took some of the doses themselves because they were afraid it was going to expire while they were in the building. And so I understand that we don't want to waste. And I hear everything that you're saying, but as a nursing leader, it's kind of like, come on, let's do what we do. And that's just my thought.
Yeah, and a solution, until we get here, but a solution can be, okay, we wait. So if there's 10 doses per vial, we wait till we have 10 residents who consent, or 10 residents and 10, 5 residents, 5 staff, whatever the combo is. And then we go ahead and get our vial and we go ahead and mix and we go ahead and give. And so we can do this in-house. We are nurses, we are trained, we know how to give injections. But we're just waiting, and our hands are tied until we get our own doses to be available in-house. It's an easy solution. We just wait until we have 10 people to be able to give the vaccine out to, and then we thaw and then we give it, rather than giving it every time everybody consents. but unfortunately, we just don't have it yet. And so the solution is going to be complicated, where we have to transfer complex residents potentially
Right.
to then get the vaccine.
No, I'm your advocate. I mean, believe me, I'm not, and I'm just super sensitive, I guess, from the weekend and this big
Know that.
RGJ exposition or exposure of a local primary care office that wasted 230 vaccines just in mishandling. And so I'm not saying we would do that, but it's a super sensitive issue. But I like that. I mean, and that's why it's great to have this conversation. We should literally propose to the governor in the task force, and Dr. Levy and Pandori and myself and others know people on this task force extremely well, that this is something that needs to be done within highly regulated, which we are, nursing facilities that more than have the capability of doing this. Let's just get a solution for it. I think that'd be a great thing to come out of this ECHO process. Is let's challenge them to work with us. I'll take it up. I'm all over for it. So anyways.
I like that idea of a pilot, Julie.
Yeah, Julie just shared it in the chat box here. I think you should ask and have a pilot facility and show them. Yeah, I think that's a good idea. All right. Any other questions from the group here today before we move on to our data update and then the didactic? All right. Well, yeah, really appreciate you asking questions, getting the discussion going here. That's what this is all about. Just giving us a platform where we can bring up these ideas and issues and talk about them. So thank you. I'll turn it back to Dr. Levy for our data update then.
Oh man, let's try it again. There we go. So good afternoon, everybody. Again, Mordechai Levy here. Just a quick COVID-19 data update, as we do every week when we meet. Here is our county tracker for test positivity rate for each county. Usually we go down over here on the right side where the graph is. So Carson City continues to decrease 8.8%. Churchill 11.1%, Clark 17.1%, Douglas 12.4%, Elko 10.7%, down from again 19.5% a month ago. Esmeralda 18.2%, Eureka is at 0%. I just noticed that. That's interesting. Humboldt 5%, below that 8%, and at that 5% WHO recommendation. Lander 3.9%, Lincoln 10.8%, Lyon 10.5%. Mineral 11.6, Nye 14.1, Pershing 5.8, Washoe 11.1, and White Pine 1.4. So generally, as you can see on all these graphs, with just one or two exceptions, almost all of our county positivity rates are going down over weeks at this point. So great job, everybody. Hopefully, we can continue to have these numbers decrease. And as Bridget mentioned earlier, start to consider what our county positivity rate as we allow visitation. This is our the dashboard for our state regarding facilities. This is the one that I showed you all last week with 11,755 confirmed cases, 732 deaths, and 19 staff deaths. So as you can see from last week to this week, so it's about, so if you look, it's 115 to 205, so 20 days. Less of an increase as far as confirmed unique cases. Deaths are still going up now at 822, and 2 more reported staff deaths from COVID-19. So this is still something, even though things seem to be leveling off, knock on wood, there's still something that's active and is really affecting all of our lives. And so making sure we continue, unfortunately, to have to remind ourselves of that. Few updates that I thought I would provide, and some of these I think were already alluded to, but Johnson & Johnson, since we've last met, has submitted for emergency use authorization for their single-dose vaccine candidate. Probably won't hear too much about this for the next couple weeks. I think the FDA is making sure that they're not going too fast, making sure they're adequately reviewing the data. So they're reviewing it over about 3 weeks or so. And so probably won't hear back from what I was last heard was around this date, but I imagine this date is subject to change as well. But my guess is it won't be sooner. And this will add another vaccine to our arsenal with different administrative qualities compared to the 2 mRNA vaccines we have. And so if this one does get approved, we can talk more about that and help answer all the questions that may be out there. CDC also updated their website with regards to kind of what to consider now that this vaccine's out there, all these new questions that we're all asking. What they did add is that for somebody that has been vaccinated and then they do develop COVID-19, they should essentially don't treat them like you would anyways, use monoclonal antibodies, convalescent plasma, antiviral treatment, or corticosteroid administration as if they had never gotten that vaccine. And so just wanted to kind of make that clear. They added this update about dermal fillers. I think we heard people that may have had a reaction because they had due to dermal fillers. And so this reaction often happens in the lips or face, but it seems to be temporary and short-lived with treatment. Sorry, I'll get that added before it gets sent out. And then they added some updated guidance to allow for more time for the second dose of administration. They're still recommending that you follow the EUA advice, 21 days for Pfizer, 28 days for Moderna, but you can allow for up to 6 weeks or 42 days after the first if it's not feasible to adhere to those recommended intervals. And so not to worry if you, for some reason, you can't get it exactly on that 21st or 28th day. The next thing I wanted to share was an article that Teresa had shared with me, and this goes back to all of this data that you all are presenting. And so this is actually information talking about vaccine uptake in long-term care or nursing homes, both staff and residents between December 18th and January 17th to kind of see how we did. They surveyed over 11,000 SNFs, our state included, and they included people with at least one vaccination clinic during the first month of the CDC Pharmacy Partnership for Long-Term Care Programs. So only includes data for those that participated in the partnership. What they found was a median of 77.8% of residents and 37.5% of staffs received more than one vaccine dose through the program. And this was taken based on data from the National Healthcare Safety Network and the CMS payroll-based journal. And so just there's kind of been more data, but just kind of wanted to show where we were in October 2020. 30% of nurses stated they were not confident that a COVID-19 vaccine would be safe and effective, and only 34% agreed that they would voluntarily receive the COVID-19 vaccine. So just kind of wanted to share this data and kind of share it also with this with the survey we took almost 4 months ago, and showing kind of the similarities there. So to kind of give us more, this article also shared information about the whole country. And so this is estimation of median percentage of residents and staff members. So residents here on the left, staff members on the right, who received more than one dose, and broken up by state. And so you can see our state here in this color, this shade of blue, 60% to 79% of residents overall took the shot. And then when you're looking at staff members, between 40 and 59% here. And you can see there's, I think the dark blue, I don't know if that's New Hampshire or Vermont, but that's the only dark blue I see here of staff members. This graph shows kind of the breakdown of who took the age groups of who took the vaccine from residents and staff members. And so you can see a larger percentage of older patients, and that's probably because, or higher percentages of older patients, which is probably because these are most of the people that are living in nursing facilities, took the vaccine. And this is kind of the ages of staff members that took the vaccine, or percentages of facilities. So that was one interesting article I wanted to share, just to kind of show what the data is showing as far as the vaccine uptake, which does sound similar to what I feel like a lot of you all have shared so far. Teresa, I was really happy to hear that your facility was so high. It seems much higher than the national average, so much different.
Can Can I actually just butt in real quick, just so you know, that's not
course.
age groups at the bottom of the previous slide. It's actually
Oh,
the percentage
percentage.
point. So if you look at like the left-hand side, of percentage of residents vaccinated, it looks like it's about 3% of residents were vaccinated, between 0 to 9% of the resident population were vaccinated. That's how you read it. So
Thank
it's like
you.
about 3% of facilities had about 0 to 9% of the residents vaccinated within that facility.
Cool, thank you. So all of these will add up to 100%. All right, thank you, Teresa. New Hampshire, thanks, Regina, that was the state. And then I know you guys probably haven't heard too much about all the work that, we're saying this is happening all over the country, all of these ECHO programs and participating nursing homes across the country. One reason you haven't heard about this too much is because that's part of the rules of engagement with the nursing home, is we have to generally, the data is going straight to the ECHO Institute and the IHI and the AHRQ to kind of gather all the data, and they'll be the ones responsible for sharing that with broader communities. But Regina did kind of refer me to one article, so I wanted to share it with you, published in the Journal of American Medical Association. And when you get the PowerPoint, this link will go straight to it. But it really gives a nice perspective of the work that we're doing together. I think Alice Bonner did a good job talking about kind of historically where nursing homes have been, kind of where nursing homes are with regards to the current pandemic, and how ECHO has done their best to kind of help support nursing homes and the residents living there. And then also potentially things to think about going forward in the future of how we could potentially continue to work together. So I wanted to just make sure that you all were aware that there is this kind of nice little editorial article out there about the work that we're doing, and wanted to make sure we referred you all to it. With that, I'll hand it back to Troy.
Excellent. Thanks, Dr. Levy. Always appreciate those updates, seeing our case numbers and everything. All right, so we'll get into our didactic today, presented by Dr. Roger Schutt, Kristen London, and Caitlin Vaughn. So here are the learning objectives. Take a quick look at those, and then I will pull up the video.
Good afternoon, and welcome to today's presentation, Visitation During COVID-19. Good afternoon. Today's speakers are Dr. Roger Schutt, Medical Director for Post-Acute Care at Beth Israel Lahey Health. Myself, Kristen Lundeen, Executive Director at Queen Anne Nursing Home, and Caitlin Vaughn, Nurse Practitioner, Director of Nursing Services at Queen Anne Nursing Home. Years ago, each of us started in entry-level positions in the long-term care arena. Dr. Schutt started as a dietary assistant in a small home in Western Massachusetts, and Kate and I both started as certified nursing assistants. Although I started so long ago in the field, you are not required to be certified. All three of us have continued our careers in long-term care and have practiced in our current positions at Queen Anne for over 15 years. This grassroots experience each of us had taught us to involve the staff in creating best practices and solving issues in our communities.
Thank you, Kristen, and thank you for joining this session of why it's important to open up nursing facilities to visitation. Humans are social beings. We crave social interaction, and when we become socially isolated, this affects us in many ways, as we'll see going forward here. The elderly are particularly vulnerable to the effects of social isolation. What are some of the effects of social isolation on the elderly? Lack of social interaction in the elderly can lead to some of the following. Changes in mood, such as depression and anxiety, may be seen. Many residents, when socially isolated, become withdrawn. Less interaction with staff members and other residents may be seen. Some residents may become anxious, sleeping less, and may become more difficult to engage in activities of daily living. In some residents, we see a decline in mentation. They become more confused, less engaged in their environment. In residents with dementia especially, we may see an increase in agitated behavior. This is most likely due to a lack of familiar family faces and conversations of past remembered events. Due to a decrease in oral intake, with some residents, we may see weight loss. We know that residents eat better when they are in a more social setting. Some studies have shown physiological effects of social isolation, such as increased blood pressure or cardiac events may occur. Some studies have even shown that social isolation may lead to premature death. These are a few reasons why it is important that we find ways to allow our residents to engage with each other and family members.
Queen Anne Nursing Home is a 106-bed skilled nursing facility located south of Boston, Massachusetts. During the pandemic, we realized our single-level layout provided us with an opportunity to facilitate continued interaction between residents and their families through window visits. In compliance with the CMS directive, we closed to visitation on March 12, 2020, as every skilled nursing facility across the nation was required to do. On March 15th, we placed window signs in each of our residents' rooms to identify the resident room number and the room telephone extension for family communication. During COVID-19 transmission within our community, we did not open windows during the visit process. Our original signs noted the family communication box we had additionally set up on our porch to aid in communication during the window visits. These items we included were pens, paper, and whiteboards, and we included window markers for families to draw on their loved ones' windows. These signs also included COVID-19 infection control reminders, such as maintaining social distance and wearing masks. On September 17, 2020, CMS issued QSO-20-39-NH, which superseded and replaced previously issued guidance and recommendations regarding visitation. In it, CMS notes they are committed to continuing to take critical steps to ensure America's healthcare facilities are prepared to respond to the coronavirus disease of 2019, COVID-19, public health emergency. CMS issued new guidance for visitation in nursing homes during the COVID-19 public health emergency. The guidance provides reasonable ways a nursing home can safely facilitate in-person visitation to address the psychosocial needs of residents. CMS also approved the use of CMP funds to purchase tents for outdoor visitation and/or clear dividers such as plexiglass or similar products to create barriers to reduce the risk of transmission during in-person visitation.
In order for visitation to be successful and safe for residents, visitors, and staff, the core principles of COVID-19 infection prevention must be followed. All staff, contracted employees, vendors, visitors, etc., who enter the building are screened for signs and symptoms of COVID-19 and receive a temperature check at a screening station upon entry to the facility. This station should be manned by an employee trained in core principles of infection prevention related to COVID-19. This employee should review answers to the screening questions and temperature before allowing entry to the visitation area. Alcohol-based hand rub should be available upon entry at the screening station, throughout the facility in common areas, in resident rooms and in hallways, and in the visitation areas. All persons entering the building should wear a face covering or mask for source control. Instructional signage should be posted throughout the facility, visible to staff, residents, and visitors, with information on infection control practices, signs and symptoms of COVID-19, and when, how, and to who to report symptoms. Environmental services staff must be trained on the core principles of COVID-19 infection prevention, including frequent disinfection of high-touch surfaces in common areas, resident rooms, dining rooms, and visitation spaces. A dedicated cohort of rooms for the care of COVID-19 positive residents should be separated and should be staffed by employees only caring for COVID-19 positive residents. Residents and staff are to be tested for COVID-19 for diagnosis and surveillance as required per CMS in your local Department of Public Health. We have trained a number of licensed staff on all shifts at our facility to perform testing, and testing is available 24/7 for staff to encourage compliance.
Virtual visitation is the alternate method of connecting residents with families and friends. It is the preferred method of visitation to minimize potential transmission of infection. As much as possible, facilities should use alternative electronic methods of communication for residents to maintain contact with their loved ones. COVID-19 affected our facility early in the pandemic. We were notified of our first positive employee case on March 24th, 2020, and we saw rapid spread throughout our facility, necessitating closing to all visits, including compassionate care visits, due to our facility's HAI rate. We met as a team and implemented the following process for residents to be able to continue to communicate with their families. We placed phones in all of our residents' rooms to use to telephonically keep in touch with families and friends, and educated staff to ask residents if they wanted to call anyone throughout the day. The iPads we previously used for our loaning program were repurposed to be used with families and friends to FaceTime. We added Zoom, FaceTime, and Skype apps to these products, and we added a tablet for resident use for families who use non-Apple products. We did apply for the CMP grant, and it purchased additional iPads through this program. Additionally, these iPads were used for families to be with their loved ones during end of life. We would often set up the iPads and leave them in the residents' rooms for privacy. We did designate a specific iPad for use in residents' rooms and used the core principles of infection control with these iPads. The Zoom calls that we set up were certainly difficult for residents to use at first, but we still have many Zoom calls that go on and keep extended families in contact to this day. Outdoor visits are preferred as the next step to virtual visits because they pose a lower risk of transmission due to increased space and airflow. Therefore, all visits should be held outdoors whenever practicable, taking a person-centered approach and adhering to the core principles of COVID-19 infection prevention. Facilities should create accessible and safe outdoor spaces for visitation, such as in courtyards, patios, or parking lots, including the use of tents if available. Have a process to limit the number and size of visits occurring simultaneously to support safe infection prevention strategies, and have reasonable limits on the number of individuals visiting with any one resident at the same time. As we progress to being able to have visits in person, we made changes to our front porch area to accommodate residents being able to have family and friends visit on a regular schedule. Outdoor visitation started our facility on June 3rd, 2020. We started with 15-minute visits, one time per week, with all visitors being over the age of 18. We were able to progress to 30-minute visits with the same age requirement after a week of the scheduled 15 minutes. We have an all hands-on-deck approach to visitation with a staggered visit schedule to incorporate required infection control cleaning in between visits, as Kate mentioned previously. Our staff had training in infection control policies and state safe transportation practices, which changed throughout the process with infection rates and updated guidance from CMS, as well as our own Department of Public Health. Set up times and dates for families to pre-sign up for a visit appointment was done through the social work team, as well as we used Sign Up Genius for an online process. One of the lessons we learned early on is that it's important to practice consistency for infection control purposes. However, you have to have some flexibility in order to accommodate the residents' requests and needs for visitors. Indoor visitation can occur if there have been no new onset of COVID-19 cases in the last 14 days and the facility is not currently conducting outbreak testing. Visitors should be able to adhere to the core principles and staff should provide monitoring for those who may have difficulty adhering to the core principles of infection prevention. Facilities should limit the number of visitors per resident at one time and limit the number of visitors in the facility at one time based on the size of the building and the physical space. Facilities should consider scheduling visits for a specified length of time to help ensure all residents are able to receive visitors. And facilities should limit movement in the facility. Visitors should not walk around different hallways of the facility. They should go directly to the resident's room or designated visitation area. Visits for residents who share a room should not be conducted in the resident's room. Our indoor visits started September 28, 2020. We screen all visitors prior to entry into our building in a vestibule area at our front entrance. We keep separate logs for visit areas for contact tracing purposes, one for the indoor visit area and one for the outdoor visit area. We do have a large living room, and based on sizing requirements, we were able to accommodate 4 visit areas. Each area is separated with a clear divider, and we do have clear dividers that can separate the resident from their visitor if so wished. All residents and staff and visitors must maintain social distance for the majority of the visit. When brief physical contact was first allowed, we posted signage and provided educations to residents and their families regarding the practice and steps to safely hug. It was certainly a challenge balancing the infection control requirements and concerns with the emotional needs of our residents. And it was an emotional week for everyone involved in the visits to see the impact of the familial touch and the effect of the residents here at our facility. After we had visits for several weeks, we were notified of an asymptomatic positive employee, which initiated a change in practice back to outdoor and virtual visits only. We learned this process is not concrete. You have to be flexible to accomplish the goal of visitation. Continued compassionate care visits after our initial stoppage of those have been allowed in the facility throughout the crisis. We screen these individuals as well. We provide PPE for them to visit in the residents' rooms, and we move residents. We're fortunate that we have several private rooms that we've been able to move residents as needed into those to facilitate the compassionate care visits. To recap, we are currently facilitating 3 types of visits to accommodate communication with loved ones for our residents. Virtual visits, including FaceTime, Skype, Zoom, and Google Duo. Outdoor visitation, including our window visits and in our outdoor visit area on our front porch. Our community has supported us strongly throughout the pandemic, and we have friends and families who have set schedules, which now include window visits on the evening walks, and families who bring their dogs who once visited inside to visit all of our residents through their windows. And indoor visits in our living room, and compassionate care visits in the residents' private rooms. We've come to approach visitation using the circular plan, do, check, act process we are also familiar with. Our residents are at the center of the process, and we make all visitation decisions using a resident-centered approach while adhering to infection control requirements. The process of visitation is cyclical, and at times all types of visits may be occurring, or you may only be able to have one or several types occurring based on HAI and positivity rates in your communities. We hope some of our experiences can assist you in developing your visitation process or enhance your current practices. Thank you.
All right. So I think that was, I think some of that might have been new information. Some of it definitely old information. And thinking about the things that you all shared in the beginning, Bridget, with you with the, I believe you called them action plan, visitation action plans that you're rolling out in all of your facilities, kind of thinking about from that QI perspective. And then also with with essentially all of these changes that we're experiencing, wanted to see if maybe that was kind of a fruitful way to discuss this, is kind of what are the, I know it's probably tough to share the actual action plans with everybody, but what are the important kind of aspects to those action plans? And Teresa mentioning having the patients, the residents, excuse me, at the center of it with what matters to them, thinking about that age-friendly health system, and I'll pull those up here as we kind of have that discussion. So feel free to share your thoughts on that.
Well, I think that we started with the action plans not thinking that our positivity rates would be so high. And each building's different. The populations that we serve are different. And the size of the buildings and locations and logistics. Can we actually, for Lakeside, for example, we can actually have visitors come into a hallway that's completely separate from the actual population of the patients right now. But I can't do that at Casa Maria because of the building and the way that it's set up. So each administrator at DON was tasked to put together a plan and then and to plot out their floor plan of how we can reopen in phases based on positivity rate, patient need. A few of the buildings have been able to go back to some communal dining, restorative dining with social distancing and proper PPE and that sort of thing. We've done a lot with the iPads and the telephone and the window visits, outside visits were big when weather permits, but we haven't brought anything truly inside other than into life. I thought it was interesting that they said that you had to be 18 years of age or older. That's not something that we've said. We've let grandchildren in to say goodbye, that sort of thing, if their PPE is correct and they screen. So I think it's on a case-by-case basis in that particular. So the action plans are individual to each building, but then following CDC and proper PPE guidance. We have not set up the plexiglass booths that have been delivered by the ombudsman at this time because we can't reopen. I think one of the buildings that I was in last week, to your point about residents, Teresa, I've known this resident for several years because I've known all these buildings forever. But anyway, she pulled me aside. She said, "I heard you were in the building. Can I please have my beautician back? Can you just get her vaccinated so that I can get a haircut?" And I was like, "I'll do my best." You know, and so then at lunchtime when I was speaking around, the girls, you know, there's 4 of them that hang out together. They were socially distanced, and they all had to have their input. So to that point, I think they're really missing out. We do activities in the hallways and stuff. It's just not the same. And what we found in one particular building, one resident, he won't even get out of bed now because he can't go out and smoke a cigarette. So he's declining rapidly based on the fact that he's isolated from his normal behavior. So anyway, I hope that answered your question. It's sort of work in progress, but at least we tried to get ahead of the 8 ball. We wrote mitigation plans for weights and wounds and different things that we thought would happen if we went positive with COVID, and then update them in copy, and then wrote the action plan so that when it's time to reopen, I don't have to reinvent the wheel.
Thanks for sharing. Definitely sounds like the physical location of all of the different facilities makes the biggest difference in kind of deciding how to best roll out those action plans, because, you know, keeping people away from each other, minimizing interactions where we're trying to avoid them, and then also kind of how we get people in and out of our buildings just with the screening protocols and the staff available. All super important things and very individualized, sometimes day to day or hour to hour, and not only facility to facility.
Point about screening, that's a big hit for, not to interrupt you, it's a big hit for surveyors. And I think, and it's really interesting starting to go back into buildings again, where working virtually is completely different from when you walk into the building. Some of the buildings have really gotten lax in their processes, and but they haven't had eyes on them. And so now the eyes are back in the building, and people are picking up again. But I believe that in 2 of my buildings that particular process was broken, and that's why they had an outbreak.
Interesting perspective. Yeah, and that goes back to Steve Matlis's point last week when he was sharing the the OSHA visits from last week. You know, I think medical services were third most common, but across all facilities, the people most likely to call about needing for a visit from OSHA are our employees and the people working there. And so making sure that we're all cohesive with that culture as far as keeping people safe, super important from so many different perspectives. So thanks for bringing that up. What other thoughts are out there? How do y'all think kind of increasing visitation is going to affect mobility with our residents?
I think that it will cause a lot of more people to want to get out of bed, and our therapy is going to have to pick up a whole bunch of people, and our restorative nursing is going to have to pick up a whole bunch of people, because we have a lot of people who are going to want to be able to get up and go see their family members outside. Not a lot of them want to do the window visits. They'll just stay in bed and do, you know, their virtual visits. But I think going outside to actually physically see them, even though they can't touch them, will motivate a lot of people, especially because if we start doing outside visits, we may start doing smoking very soon. And I have quite a few patients who do not get out of bed because they are not allowed to smoke, and they are protesting every single day that they can.
Yeah. Thank you for sharing. Yeah, I know from a geriatric perspective, I know when people are not moving much and then they start moving more, I worry a lot about falls shortly happening after, and the different things that happen after falls, which I know we're all very familiar with.
Yeah,
Michelle,
Modi,
I was wondering,
can I just, Steve here, just on the 4Ms, there are a couple interesting things that are coming out. You know, being on the editorial board for the Journal American Medical Director Association, I'm starting to review some articles around medications. There's a discontinuation of upwards of 20% of medications around COVID-19, which I find very interesting. And there's going to be more and more work around that. The other is the increase, you know, those of us who know the lingo, you know, the MDS every, you know, initial admission, then every 3 months thereafter, or change in condition. The increase in depression through the PHQ-9 is really escalating. And so I really think that, you know, I'm really happy you brought up the mobility and the potential for falls, if not anticipated, because of less function and being bedbound. Though the medications and mentation are already starting to be reported and soon to be in the evidence-based literature. So it's just something that, Bridget, I love your high-level overview of what's going on and how individualized it is. Though I think these are things we can jump on with regards to medications, mentation, and always what matters. I mean, that's always an ongoing conversation. Though the increase in depression, I think is going to be a significant factor.
I think you're correct. It's sad, but and I have to be high level and overview, but when you drill it down, it's the people that are the most important thing that we do every day. And if that's not why we're here, then we shouldn't be doing what we do.
Cool. Yeah. Thanks, everybody. I think the only other thinking about all those things that you mentioned, Michelle, with PT and restorative nursing, and with our numbers going down, people getting vaccinated, people potentially wanting to get visitation. Wondering if you'd kind of talk to that, you know, kind of share some of those thoughts or concerns that you have with those teams as far as coming up with a way to maybe mitigate some of those potential mobility issues, so there's not such a big stress on the system once people all kind of want to start moving at once.
So as Dr. Phillips was talking, we have MDS every quarter. We have our people who are due to have their MDS done, and so we have them evaluated. And so at that time they will be evaluated. So about every 3 months, everybody in the facility is evaluated. So there is some going on, and then we do have our RNA program that's going on right now as well. I just think the ones who right now are not cooperating or not willing to do restorative or therapy, when we start being able to let those outside visits happen or the smoking happen, that's when they're going to say, oh, wait, yes, I want that because I want to be able to get up and go do these things again now. So once we get more activities, I think a lot of patients will want to get out of bed now. Right now, they don't care. I can't do my activity. Why get out of bed? There's no need.
Okay, so they're having a hard time looking forward to the time when things might be different. Yeah, and that goes a lot to what Dr. Phillips was sharing with depression and how people are feeling, because those all go together. Thank you for sharing. Appreciate that, Michelle. Any other thoughts before we move on to final announcements?
I was just interested, Mark Donardo said it was a very good video on visitation. I was just interested in understanding what you were able to take away, Mark, that made it useful for you.
So for me, I think just starting the conversation, as we've been so ingrained, and rightly so, with COVID, but you know, the industry is nursing facilities. They're the residents' home. So we need to do everything we can to mitigate the infections so that their home is, you know, a safe environment. So, you know, I just liked what the video, the person in the video was doing with their facility. I think they're, you know, putting a lot of thought in it.
Mm-hmm. Thank you for that. Thanks for sharing. Appreciate it.